You have just been diagnosed with a severe herniated disc. Your leg is burning with sciatica. Your lower back is in constant spasm, and you are desperately searching the internet for a cure. You are terrified of open spine surgery. You do not want massive incisions, metal screws, or general anesthesia. Naturally, your research leads you to advertisements for laser spine surgery. It sounds like a miracle, a magic beam of light that instantly evaporates your pain with zero recovery time. But what if I told you that for half of the patients watching this video, the laser will completely fail? What if your specific anatomy makes the laser totally useless? Today, we are going to strip away the marketing. We are going to examine the hard mechanical physics of the two most advanced minimally invasive procedures in the world: percutaneous laser disc decompression and endoscopic discectomy. We will explain exactly how they work and exactly why your MRI dictates which tool will cure your pain. To understand why one tool succeeds while the other fails, you must understand the anatomy of a herniated disc. Think of your spinal disc as a heavy-duty water balloon holding up a heavy weight. The thick, rubbery outer wall of the balloon is called the annulus fibrosus. The pressurized gel inside the balloon is called the nucleus pulposus. When your spine experiences severe wear and tear, two very different things can happen to this balloon. Scenario 1, the rubber wall weakens and stretches, but it does not tear open. The pressurized gel pushes the wall outward, creating a large bulge that presses against your spinal nerve. Scenario 2 is much more violent. The rubber wall completely tears open. A large piece of the pressurized gel violently explodes out of the balloon, breaks off completely, and falls into the spinal canal, directly crushing the nerve root. Scenario 1 is a contained bulge. Scenario 2 is an extruded, free-floating fragment. These are two completely different mechanical problems, requiring two completely different surgical tools. Let us look at the first tool, Percutaneous Laser Disc Decompression, or PLDD. This is an incredibly elegant, ultra-minimally invasive procedure. It is performed through a tiny needle. The patient is awake, using only local anesthesia to numb the skin. Under live X-ray guidance, the surgeon advances a microscopic laser fiber directly into the center of the damaged disc. Here is the mechanical truth about the laser. It does not cut, it vaporizes. When the laser is activated, it evaporates a tiny amount of the water-rich gel inside the center of the disc. By destroying this gel, the internal pressure of the disc drops dramatically. It creates a vacuum effect. If you have a contained bulge, meaning the rubber wall is stretched but still intact, that vacuum will literally suck the bulge back inward, pulling it safely away from the nerve root. It is an indirect treatment. The laser never actually touches the nerve, and it never touches the bulge. It works purely on the physics of pressure. Now let us look at the second tool, Endoscopic Discectomy. This is a direct, targeted surgical removal. The surgeon makes an 8mm puncture in the skin. Using a series of smooth tubes, they gently separate the back muscles without cutting them, creating a tiny tunnel directly to the spinal canal. An endoscope, a high-tech tube with a high-definition camera and a light source, is inserted. The surgeon looks at a large monitor in the operating room and can directly see the trapped nerve root and the exact piece of herniated disc crushing it. Using microscopic mechanical graspers, the surgeon physically grabs the herniated fragment and pulls it out of the patient's body. The pressure is instantly relieved. The nerve is freed. It does not rely on vacuums or indirect pressure. It is a physical, direct extraction under live, highly magnified visualization. So, why does the laser fail 50% of the time? Because patients demand the laser when they actually have a free-floating fragment. Remember the water balloon analogy. If the rubber wall has completely torn open and a piece of gel has broken off and fallen into the spinal canal, creating a vacuum inside the disc is completely useless. The vacuum cannot suck a disconnected piece of gel back inside a torn balloon. If you use a laser on an extruded fragment, the procedure will fail, and the patient will wake up in the exact same agony. This is why elite neurosurgeons must meticulously analyze your T2-weighted MRI before touching you. We are not just looking at the size of the herniation, we are investigating the structural integrity of the annulus fibrosus, the outer wall. If the dark black line of the outer wall is intact, you are a perfect candidate for the laser. If the white fluid has breached the wall and dropped behind the vertebral bone, the laser is obsolete. We must use the endoscope to physically grab the disconnected fragment. Both of these procedures were pioneered decades ago to save patients from the destructive muscle damage of traditional open spine surgery. Percutaneous laser disc decompression was pioneered in 1986. It is the absolute least invasive option available. No incisions, no stitches, and the fastest possible recovery. But it has a lower overall success rate, hovering around 60 to 70%, because it relies on indirect vacuum pressure. Endoscopic discectomy evolved in the 1990s specifically to fix the limitations of the laser. By putting a camera inside the spine, surgeons could finally see what they were doing. Endoscopy is slightly more invasive, requiring a tiny incision, but its success rate is staggering, often reaching 85 to 95%. It is highly reliable, highly predictable, and fixes almost any type of herniation, no matter how large or fragmented. You should never choose a surgical procedure just because the marketing sounds appealing. The laser is not a magic wand, and the endoscope is not for everyone. Your unique anatomy and the exact physics of your herniated disc must dictate the tool we use. Every spine is unique. Do not rely on generic advice or glossy advertisements. Let our expert neurosurgeons review your complete medical history and imaging. Click the link in the description to upload your MRI or CT scans to our secure portal. We will map the structural integrity of your spinal discs, provide a definitive, personalized second opinion, and tell you exactly whether you need the gentle suction of a laser or the precise removal of an endoscope to cure your sciatica permanently.